In today's video, I'm going to discuss why I chose surgery over the non-surgical route. So I'm about 1 week out of my plaster cast and 3 weeks post-op. Just a little update, they put me in this ratcheting brace where I increase my extension by 10 degrees every week. So I started off around 40, next week I'll be at 30, 20, 10, and then finally I'll take it off and I'll be back to being a normal human. But as compared to my previous cast, this thing is like a Bugatti versus a Toyota Corolla. I can take this off to shower normally. I actually have some range of motion. If I get sweaty in the gym, it's not just trapped in there like it was the last time. I can wear a long sleeve shirt. I can wear a jacket. Just sky's the limit with this thing. Obviously, compared to not wearing anything, it is still a little bit. We all know that raw dog feels the best. There ain't no disputing that. But beggars can't be choosers. And so this is what I got for the next couple weeks. So if you've done your research, you've seen that there are two ways to heal this type of injury. There's the surgical route, which I chose to undergo. And there's the non-surgical route, which is becoming more and more popular with time. I mentioned in my last video that about 30 years ago, anyone who showed up to the emergency room or to the orthopedic surgeon with this type of injury were immediately put on the surgery schedule. There was no other therapy. There was no other modality of treatment for this type of injury. It was reattachment of the tendon to the bone and then rehab, basically your old school way. And in your surgical route, there are two different types of procedures that can be done. There's the endo button, which is what I've had, and then there's the double suture method. Both of them reach the same outcome in terms of reattachment of the tendon to the bone, but they are different in techniques and also in healing time. The endo button is a procedure where they attach what's left of the tendon to some sort of coin-like structure, which is a little bit longer on its horizontal axis and thinner on its vertical axis. And then they drill through the radial tuberosity, which is where the tendon of the bicep is supposed to insert originally. They insert the endo button, feed it through vertically on its thin axis, and then they turn it over on its transverse axis so it can't come back up through the bone because it's wider on its horizontal axis. And so because of that, the tendon stays inside the bone and allows for the bone to heal onto the tendon, holding it in place. And so that's the process that I'm in right now. The surgery is done, 2 weeks post-op, tendons in the bone, endo buttons beneath the radius, and I'm just waiting for osseointegration. It needs to close, needs to come together, which is why I'm still in a brace. They don't want any forceful movements of you using your bicep, which can dislodge or can move that tendon around, which can cause complications in the healing process. I'll explain my thought process and why I chose surgery as opposed to non-surgery. So it's a combination of me finding data online, reading papers, speaking to my orthopedic surgeon, my experience from healing from a tendon injury, put together, allowed me to choose what I feel like is the right option for me. The reasons and steps I underwent in order to choose surgery over non-surgical route were a little confusing at times. So some major differences between the surgical and non-surgical route include overall maximal force output for specific movements. And in this case, it's flexion and supination. So flexion is when you make your bicep curl or your typical in the gym mirror selfie. You're just pumping the guns for the ladies. Supination is when you are turning your hand or your wrist over. So the way they taught us in pre-med was if you can hold a bowl of soup, you are supinated. Meaning if your palm is faced up, you're in supination. And so that movement, when you're twisting the palm upwards, that is a major function of the bicep muscle. And so it's only right to assume that if the bicep muscle is detached, that you're going to lose a major force output for that specific movement. And so the literature shows that your maximal flexion at the end of therapy, and once you're fully rehabilitated, is on average about 70% of the maximum, which means you lose 30% top end, which isn't bad. But your supination is anywhere between 30 to 40% of your maximal output prior to the injury. Now that's a little scary. Losing anywhere from 60 to 70% of something that you were able to do normally prior to the injury, and only being able to do 30 to 40% of something once you're considered fully healed, to me stood out. I had to think about that for a while. Can I continue with what I do day to day with only 30 to 40% of supination? And at first it was an automatic write-off for this conservative therapy. I didn't want to think anything of it. I was like, I need top-end supination, I need top-end flexion, even though I didn't really think of what I was doing during my day that required that. But then I did more research. I spoke to my orthopedic surgeon. He obviously gave me the list of complications that can arise with surgery, some specific to this type of surgery, and some that are just inherent for any type of surgery where you're put under, an incision is opened up in the skin. Complications that I was worried about the most were obviously motor damage. If you were to nick a nerve while trying to complete the procedure that I explained earlier, then there is a chance that you lose motor nerve function of everything from the elbow down. And so for me, losing obviously movements of my hand, my fingers, my forearm, that was a big worry and something that I wasn't really willing to risk if the conservative therapy would lead to this same outcome. Now for me, I can live with losing 30% of my flexion and 60% of my supination, even though it sounds like a lot. Because if you think about it, normal day-to-day activities and tasks don't necessarily require you to be hitting those top end limits of those movements. You're not curling something where you require more than 70% of your natural ability. You're not turning your wrist over or supinating something day to day where you need 60% of your maximal supination. I believe that unless your profession requires you to have specific force outputs, then you should really consider the non-surgical route. What tipped the scales and made me choose surgery over non-surgery was the fact that across the board, most non-surgical patients, once fully healed, showed that they had higher rates of fatigability when time and load was standardized. And so that basically just means that people who underwent the conservative therapy got tired quicker doing the same movements as the people who underwent surgical therapy. And so for me, and what I'm expecting to do with this arm, my profession, I need to be able to come back to something where my rate of fatigability is comparable, if not the same as it was prior to the injury. I can live with sacrificing 30% of my flexion. I can live with sacrificing 60% of my supination. I don't plan on entering any jaw opening competitions or arm wrestling competitions anytime soon. But if I get tired using this arm, then that will start affecting my work.